Good morning. Welcome to the Satellite Symposium hosted by Caristo during the SCCT 2021. I'm Jagat Narula with my friends Ron Blankstein and Nehal Mehta, discussing today CT angiography, inflammation, and prevention. CT angiography has matured as the most important imaging modality for the assessment of coronary artery disease within the last 20 years. It not only provides the extent of luminal stenosis, but addresses the vessel wall characteristics which promise to be the determinants of prognostic outcomes beyond anatomy and physiology. The two most important determinants of so called high risk plaques are the volume of the plaque burden and necrotic core, and the extent of plaque inflammation. Whereas the necrotic core is relatively easy to define by low attenuation plaques, newer computational technologies are making it possible to measure the plaque inflammation. Let's discuss the expanding horizons of plaque assessment today with the two stalwarts in the field. Let me first introduce Dr. Ron Blankstein, who obviously needs no introduction. Professor of Medicine and Radiology at Harvard Medical School. He is the Associate Director of Cardiovascular Imaging Program and Director of Cardiac CT and Preventive Cardiology Specialist at Brigham and Women's Hospital. He is also the immediate past president of the SCCT and serves on the board of directors of American Society of Preventive Cardiology. Prolific publisher Dr. Blankstein will be speaking to us about the importance of coronary inflammation in CVD prevention. Ron, thank you.
Jagat, thank you very much. It's a great honor to be part of this symposium, particularly as it is chaired by you, someone who has taught us so much about plaque imaging. Well, I'll be talking about inflammation today, and just to kind of get started here, some of my disclosures on this slide right here. And I would share with you that over the last decade, I have been interested in this concept of why are we seeing more myocardial infarctions at a young age. I became interested in this when I learned that this is a true statistic across the country, that we're seeing more MIs in young individuals. I have a terrific research team, and we've looked into this. But the bottom line is that almost all individuals who experience an event at a young age have underlying risk factors. So the concept that these are events that are happening out of the blue, as some patients believe, is simply wrong. And when we look at those risk factors, they include, of course, smoking, which is the most common reversible risk factor, but obesity, diabetes, substance abuse, some sex-specific risk factors, and certainly inflammation. Patients with systemic inflammatory diseases are at higher risk. Now, despite the higher risk, it turns out that if we were to take patients who have a myocardial infarction and look at their risk factors, perhaps a few weeks, months, or years before their event, the majority of them would be classified as low risk by our guidelines and would therefore not be candidates for statin therapy. This was seen in the Duke registry and also in Boston in our Young MI registry. So naturally, the question that many ask is, can we identify risk in these young individuals using a CT scan? And to date, there's been several studies looking at the role of calcium scoring in young individuals. These include the Cardia study, the CALC Consortium, and recently the Western Denmark Heart Registry. And a common theme here is that once we see any plaque, even just a small amount in a young person, that's associated with a higher risk of event. Despite this, even if we were going to treat individuals based on this, the reality is that most individuals who are young, even if they're identified at high risk, are not treated with therapy, or if they're treated with statin therapy, it's often low dose. Now, regardless if the patients are young or older, statin therapy is always a good start. But I think one of the important things for us to realize is that the event rate reduction with lipid-lowering therapy, typically we're looking at relative risk reductions of 20 to 30%. So I like to remind my patients that the glass may still be 70% full. Fortunately, we now have multiple therapies that may address this residual risk. But we really need to understand what's driving it. For some patients, it's inflammation. If the residual risk is due to elevated LDL cholesterol, PCSK9, if LPA is high, we have some therapies in the pipeline for that, and so forth. So we have a lot new therapies, but we really need to understand what's driving the residual risk. Not every therapy here is going to be appropriate for every patient. When it comes to anti-inflammatory therapy, one of the questions is, can cardiac CT identify coronary inflammation? And I think it's very exciting for us in 2021 to say that the answer is yes. This is an example on the left side of this slide of a 52-year-old male with diabetes from Brigham and Women's Hospital. And for investigational purposes, we were able to look at the pericoronary fat attenuation, or Phi index. As you can see in this scan here, the coronary fat or pericoronary fat here is depicted by different colors. And ultimately, we can look at the percentile for the Phi score. So the Phi score reflects how much pericoronary inflammation there is. This is dependent on age. And in this particular patient, the percentile is at the 81st percentile, so a high percentile. And we can combine this with risk factors and develop a risk score. This is not something that's currently FDA approved. This is all investigational. But the concept here is very exciting, that this information predicts risk. And importantly, this is additive on top of other plaque features, high-risk plaque features, and it's even additive on top of the calcium score. And I always say it's very hard to beat the calcium score, but this is incremental risk in risk specifically that ties to coronary inflammation. So if we can potentially identify patients that have a higher level of inflammation, the next question is, do we have therapies for that? And thanks to my colleagues at Brigham, Paul Redker and Peter Libby, this is an article here showing some of the therapeutic targets, which in some of the agents that have been developed, which include old agents like colchicine, and now IL-1 under a new big trial, IL-6 blockers. If we were to summarize a lot of the data that we know to date, we have seen a very important signal from several trials showing that a reduction in inflammation via pharmacotherapy leads to lower event rate. The CANTOS trial showed this was a 15% relative risk reduction. And recently, also several studies using colchicine, both in patients with prior MI and patients with stable coronary disease. Importantly, the benefit in these trials is perhaps modest, even though it's similar to the benefit that's observed with some of the PCSK9 inhibitor therapies. And this is despite the fact that the population in these trials is an unselected population, just patients with coronary disease in some of these trials using colchicine, or patients who are selected based on having an elevation in systemic biomarkers such as CRP. So these are non-specific markers of inflammation. They don't necessarily tell us that the inflammation is happening in the coronary arteries. So certainly, I think the really important need is to identify tools that can detect coronary inflammation, because that may allow us to identify patients who are most likely to benefit from anti-inflammatory therapy. And certainly, these are therapies that are expensive. They have significant side effects in some of the studies. So we need to know who are the right patients, and CT now potentially may help. So for my conclusion, I would first state, as I always do, when it comes to prevention, healthy lifestyle matters at all ages, and that's always where we should start. When it comes to individuals who are young, and when it comes to preventing disease that starts in earlier ages than most of us appreciate, we do need better risk assessment so we can start therapy earlier in life. I certainly think there's a role for imaging, but it's never in isolation. It's together with other risk factors, and this could lead to earlier pharmacologic therapies. Now, these therapies typically are just lipid-lowering therapies, and we now are in a new era where we have to identify what is the residual risk that the patient may have that could be modified by other therapies. And specifically, if we use coronary CTA and do a Phi analysis, we can identify patients with pericoronary inflammation. And these are the patients that have a higher risk, needs more aggressive lipid-lowering therapies, perhaps need other preventive therapies, but also are the ones who we should target in the future, anti-inflammatory therapies. So very exciting era up ahead for all of us in this field. With that, thank you.
Thank you very much. And now, to translate it to inflammation or identification of inflammation, we have none other than Nehal Mehta, the director of the section of inflammation at NHLBI. Dr. Mehta started his career at the NIH in 2012 as the inaugural Lasker Clinical Research Scholar. He is also regarded highly in the psoriasis circles. He studies psoriasis patients as an accelerated model for development of atherosclerosis. He will speak to us for the next 8 minutes on the role of fat attenuation indices in the evaluation of coronary inflammation. So, Nehal, thank you for joining us today.
Jagat, thank you. Ron, thank you for a great talk as always. And I would like to thank the organizers for being able to speak today on the role of Phi in the evaluation of coronary inflammation. My name is Nehal Mehta, and I am delighted to remind everybody that atherosclerosis is an inflammatory disease. It is the leading cause of heart attack and is accelerated by inflammation. In fact, understanding inflammation and its presence is critical prior to the heart attack, and I think we got that sense as well from Dr. Blankstein's talk. My lab has studied for the past decade or so the role of inflammation in driving vascular disease and poor vascular health. And in fact, the role of inflammatory cells around not only the culprit artery, but throughout the endovascular tree. And this is the story of a 38-year-old male with a chronic inflammatory disease, psoriasis. And what this shows is that there's a positive remodeling, low attenuation plaque shown in panels B and D. And this chronic inflammation drives these high-risk coronary plaques, who's 38 years of age. Between his baseline visit and 1-year visit in our study, he suffered this right posterolateral myocardial infarction. And shown in panels E and F is the presence of high-risk plaque features, specifically a lipid-rich necrotic core, as well as this positive remodeling or outpouching of the coronary artery. But the question is, can we detect this before it happened? So one of the things that we have been working with Caristo on is using the perivascular fat as a sensor for coronary inflammation. And shown here on the left is a healthy non-inflamed artery. There's no paracrine signals going out, as in on the right, where there's a healthy inflamed artery. What is characteristically unique is that the adipogenesis, lipolysis, and edema changes, and the lipid and water content have a modulation by which one can detect what is going on in the coronary before the plaque has started. And this perivascular fat attenuation, PFI, serves as a sensor for detecting coronary inflammation. So how does it work? Seeing these changes on a conventional CT angiogram permits the detection of that differential lipolysis edema ratio and characterizing this fat and how it attenuates due to the amount of inflammation in the coronaries permits Phi as a biomarker, and a biomarker that has been validated against 1,400 biopsies, so radiotranscriptomics. And shown on the bottom left, you'll see that in the absence of luminal disease, there's low Phi on the left side, whereas there's high Phi on the right side, indicating a high amount of coronary inflammation. When this fat attenuation index is present and it's abnormal, it has prognostic value for future adverse cardiovascular events. This cohort consisted of European as well as United States, totaling over 4,200 patients. And what the findings were that when there was an abnormal amount of fat attenuation, there was a 6 to 9 times higher risk of fatal heart attack and a 5-fold risk for non-fatal heart attack. In fact, the European Society of Cardiology and the British Heart Foundation called this a game changer, noting that beyond high-risk plaque features, beyond the traditional risk factors, including calcium scoring, Phi had prognostic value. Furthermore, I showed you our young patient, 38-year-old with psoriasis, chronic inflammation, and how he had a high-risk plaque. Well, what does Phi add when you look beyond high-risk plaque. So shown here are high-risk plaque features, including the napkin ring sign, low attenuation plaque, spotty calcification, the low attenuation plaque plus positive remodeling. What happens when you add Phi to this? And if you look around for coronary inflammation, and what the 2x2 table on the bottom left shows is that those who have the high-risk plaque feature as well as high Phi had more cardiac mortality 7.5 years prior to additional study. So in addition to high-risk plaque features being characterized, Phi even adds to that prognostic value. And finally, how did I start working with the fat attenuation index? One of the first things that I was looking for was a dynamic biomarker. And Phi, demonstrated here in 3 separate studies, shows that it is. Shown here is a patient with severe psoriasis, and this is fat attenuation on the left at baseline, and on the right, followed by 1 year of biologic therapy. In fact, anybody who went on an anti-TNF, anti-IL-12/23, or anti-IL-17 for psoriasis skin disease saw a reduction in their perivascular fat attenuation, indicating that their coronary inflammation improved. Furthermore, after a ST elevation MI and following PCI, one detects that Phi reduces over time, as well as correlates with the amount of plaque inflammation burden following optimal medical therapy. And in fact, the changes in inflammation post-STEMI demonstrating here that as one provides healing medications for vascular health, there is an improvement in coronary inflammation. However, not everybody saw this reduction in coronary inflammation, suggesting what Ron had brought up, that there are patients who require more than the conventional therapy and possibly even an anti-inflammatory. So in conclusion, I demonstrate to you that inflammation promotes this high-risk plaque development, which ruptures prior to clinical symptoms, and we must do better in detecting those people. Secondly, PPHI accurately assesses coronary inflammation, which contains important prognostic information by coronary CTA. And third, assessment of PPHI, in addition to high-risk plaque by CTA, may provide even more refined risk assessment. And with that, I'd be happy to take questions and turn this back over to Dr. Narula. Thank you.
Thank you, Nehal, for an excellent, excellent overview and summary of the Phi, which is the basis of today's satellite symposium. And now I have time, I think, for about 4 questions. If we could just do the answers within about 2 minutes' time for each question. And I think, to be fair, I'll ask 2 from Ron first and 2 from Nehal. Ron, whereas we do talk of calcium scoring and would like to make it like a colonoscopy type of a test, why don't we do more CT angiography for primary prevention? Would it not be more informative than the coronary calcium score?
Yeah, Jagged, that's a good question, and I think in many ways it is more informative. You do learn more about overall plaque analysis, but the incremental value. The question is, before the era of Phi, we can use a calcium score to say how much plaque someone has. So the incremental value of the coronary CTA may be relatively small for some of our patients, and that's okay. It's extra information, but I think to me the biggest worry is when we do coronary CTA, we find stenosis, and there's the potential for folks to overact on that. And we now have asymptomatic individuals, maybe it was a mild or moderate stenosis, and then they get unnecessary downstream testing. That's been one of the concerns. So as long as we know how to use the information and we use it correctly and it doesn't trigger unnecessary information, I think there's a case to be made, at least in some individuals, that coronary CTA would help. Now, I think there's important studies in the pipeline that may kind of usher an era of coronary CTA for some patients. And one of the studies looking at this right now is the Scott Hart 2 study. So depending on the results of that, that might provide some more rationale for coronary CTA, at least for some of our patients.
I mean, Scott Hart 1 did tell us that to an extent, right?
Yeah. So just for
So
our listeners, the biggest difference is Scott Hart 1 was symptomatic individuals for the most part. Scott Hart 2 is a trial in asymptomatic individuals. So we're talking about, I think the question was about the role of coronary CTA for asymptomatic individuals. We can definitely see more, we can detect more. We just have to make sure that we use that information appropriately.
right. I mean, and I think that gradually the boundaries between the symptomatic and asymptomatic probably would gradually fade off too. But nonetheless, let me ask you one more question before I go to Neha, and that is inflammation just not a consequence of LDL? People say that it is all about fat. Fat is a foreign material which is getting into the plaque, and it is causing the inflammation. So, and if so, should we just be focusing on LDL? Or does it stand an independent ground and deserve importance at the equal footing, quite like the lipids? Should both be important, or we can just get away with the lipids?
Yeah, no, I think that's a great question and a very important one. And I think that the important principle is these are different pathways. So LDL lowering does not really affect inflammation a whole lot. And when we think about inflammation, there's multiple reasons for that. So for some folks, it's the diet. And dietary changes can be very effective to reduce inflammation. And for some patients, it's systemic inflammatory diseases. And we're learning more and more about conditions that are associated with inflammation. For example, elevated lipoprotein A is a pro-inflammatory molecule, something that a lot of us are not aware. So this is the bottom line is this is a different pathway. And this is why even when we lower LDL and even when we bring LDL way down, for the right patient, there is that residual risk that we can address by lowering inflammation. And we've seen this now in the CANTOS trial. There's now several other trials underway. So I think this is kind of a new era, hasn't been explored. And I think the key is finding who are the patients that have inflammation. It's not going to be everybody. Not every patient with coronary artery disease is going to have a high level of inflammation.
Thank you, Ron. I mean, I think that was a great analysis of that very contentious question, actually. And now let me go to Nehal. And Nehal, who are the patients that are likely to have more residual inflammation? Remember the glass that Ron Blankstein showed us with a 30% sitting on the top here, probably. And are there patients with super added inflammation, or are there any patients who have got the out of proportion inflammation?
You know, it's interesting, Jagat, that you bring this up, and Ron's glass analogy is actually excellent because if you think about it, biased, I'm going to say those with chronic inflammatory disease represent sort of a window into what we're missing. There's also an epidemic of acute MIs among young, obese Hispanic males, about 4.5-fold. And a lot of that is driven by this same cardiometabolic insulin resistant state of inflammation. So, who would benefit from it? Well, it's those who are probably intermediate risk that would really be missed by traditional risk factor scoring. So, if you look at our chronic inflammatory population, there's been a lot of questions coming through the chat about whether this is available clinically. And I think it's a stay tuned answer. It's not quite cleared here yet, but is being used at the NHS in the UK on all scans being done there. But the patient that I vision using this for is the patient who has risk factors that are probably related to those that drive inflammation. So your obese patient, high BMI, maybe has a high CRP, but again, we know that CRP doesn't seem to capture all the risk and inflammation as well, especially in those with chronic inflammation. I think of my young heavy smokers who probably would not have luminal disease. And I mean, looking at Ron's young MI cohort has taught us that a paucity of traditional risk factors does not mean you can't have an acute MI. So Phi here really could help us tailor not only more aggressive primary prevention measures, but also identify those who are slipping through the cracks through the risk scores, like the patient that I brought up who was 38 and had that acute ST elevation MI, Jabba.
So, although I think I was thinking of yet another question, but I think quite a bit of it you have already answered. But let me frame it again specifically for the benefit of the audience here. That how do you see the phi being used in future? In all CT angiographies, in some selective CT angiographies, would it become necessary that we report on calcium, luminal stenosis, lipid burden, and inflammatory index in all of them? Or or how would you specify that?
That is a very tough question. And if I had it my way, all of what you said above would be reported on a standard CT, but we know that that's just not entirely possible. So, first, if there's a CCTA done for risk assessment, let's say it is for risk stratification, I do believe that PHI, very easy to obtain and hopefully soon clinically available, will serve as a great biomarker along with getting the CCTA, right? So if one is already committed to the CCTA, there shouldn't be an extra, step thinking about getting a PHI. I think that the patient who is going to most benefit from it is the patient who yet has not developed any luminal disease, but is at risk for developing it in 3 to 5 years. So your 35 to 45-year-old who has family history of MI may not be captured unless you use a Reynolds risk score, for example. But I think that that's where I see PHI really fitting in, is it will be kind of the imaging biomarker in addition to what we would do clinically as well as from traditional risk factor management.
So, ladies and gentlemen, I am grateful to these two stalwarts, and I hope that you enjoyed it and learned as much as I did from these two very elegant talks. And the advances in CT angiography and the technology is likely to consistently improve patient care. Seems we are evolving from simply obstructive plaques to hot plaques, and now red hot plaques. We will always be available for any questions should you write to us. Both the talks, they had the emails addressed on the bottom, and or you can just simply write to the scct.org as well. Or in the questions that we have gotten through the chat box, we would be happy to respond to them through the email. So until the next time, if Jessica and Kristen allow me, I think I would close the session and thank you for joining us. Have a great day. Thank you.